Thank you, and happy Monday, everyone, and welcome to today's presentation titled Promoting Integration of Care, the Role of Pediatricians to Support Youth Mental Health. Before we begin, we would like to mention that this is a safe and friendly space for positivity and productivity. There are a few housekeeping items I'd like to quickly go over. This presentation is being recorded, and the recording link, slides, and a letter of attendance will be sent via email to everyone who attended today. This information will also be available on ASTHO's, NAMI's, and NASHPD's websites and NASHPD's YouTube channel. Please use the chat pod to share your name and state, ask questions, and/or share information with the group that pertains to this presentation. Closed captioning can be viewed by clicking the CC at the bottom of your screen or clicking the link in the chat pod to view in a separate window. After the presentation ends and you leave this platform, a brief survey will show in your browser. Please take a few moments to share your comments and thoughts with us about today's presentation. We would like to give special thanks to SAMHSA for sponsoring this series. And again, thank you for joining us. I will now turn this over to Catherine Gilley, Senior Manager of State Affairs, Government Relations, Policy, and Advocacy for the National Alliance on Mental Illness, also known as NAMI. Thank you. Thanks, Catherine.
Great. Thank you so much, Kelly. And thank you everyone for joining us today for this SAMHSA-sponsored webinar. Today's webinar is the fourth and final in a four-part learning series titled Leveraging Different Sectors to Address the Youth Mental Health Crisis by the National Alliance on Mental Illness and the Association of State and Territorial Health Officials. In previous webinars, we focused on the public health, education, and nonprofit sectors, and the recordings for those are available on our websites, and I'll drop a link toward the end of this webinar. Today, we are very excited and honored to have Dr. Warren Ng, President of the American Academy of Child and Adolescent Psychiatry, and Dr. Sandy Chung, President of the American Academy of Pediatrics, present on the role of pediatric providers and collaboration opportunities between child and adolescent psychiatrists and pediatricians to expand youth access to mental health care. In addition to their roles as their respective board presidents, Dr. Ng is the Medical Director of Outpatient Behavioral Health and the Director of Clinical Services for the Division of Child and Adolescent Psychiatry at Columbia University Medical Center and New York Presbyterian Morgan Stanley Children's Hospital. He is also the New York Presbyterian Behavioral Health Service Line Clinical Innovation Officer. Dr. Chung is the CEO of Trusted Doctors, a pediatric practice of over 180 clinicians in Virginia, DC, and Maryland, and serves as the Medical Director of Informatics at Children's National Hospital's Pediatric Health Network. So if we can go to the next slide, please. Just want to provide a quick disclaimer that this webinar is sponsored by SAMHSA, but the views, policies, and opinions expressed are those of the authors and not necessarily of SAMHSA or HHS. Please post any questions you have in the chat. We'll have about 15 minutes after both presentations for Q&A. And with that, I will turn it over to Dr. Warren Ng.
Thank you so much. And thank you everyone for joining us this Monday to learn more about pediatric providers and youth mental health. We're very appreciative of all of your service and everything that you all contribute to the well-being of young people around you, as well as within your communities. Next slide, please. We're all here today to appreciate what we already know is happening. And I think one of the things as a child and adolescent psychiatrist that I'm acutely aware of, but I think for all of us, is that mental illness starts early, and really appreciating the fact that we are at the moment we are, primarily because of the lack of attention to children and adolescents and mental health in the past. And I think it's wonderful that we're all here today to really address that and to try to move those issues forward. And we're really grateful for all the partnership, SAMHSA, NAMI, and all of the federal agencies in trying to create a path forward. One of the things that is very clear is that mental illness shrouded by stigma has been silent. And I think when we appreciate that 1 in 5 children and youth experience a mental health or behavioral disorder, that's a lot of children, if not the ones that we have in our care, then the ones around us within our communities. Also appreciating that half of all mental illnesses start before the age of 14 and about 75% before the age of 25. So we can appreciate that the earlier that we're able to intervene with early identification, as well as addressing support for both the young person and their families, is critical. We also have the reality that suicide is the second leading cause of death for young people 10 to 14, and the third leading cause of death for those 15 to 17. We are at a moment in our country where suicide has been increasing, and the past year in 2022, suicide for all members has been the highest in our history. So I think that this definitely acknowledges the importance of this moment, but also ensuring the safety, the protection, and the services for our young people is critical. Next slide, please. So when we're thinking about our national scope and in appreciating where we are at with children's mental health, young people represent about 22% of our nation's population. That's 73 million children. And in an earlier study, looking at how many children were impacted, almost 8 million children have a treatable mental illness, but less than half of them are receiving any kind of treatment. And that's not even thinking about what are evidence-based treatments, as well as treatments that are centered around youth, families, and communities. We're also thinking that there's often a gap between the time that a young person presents with symptoms or illness and then receiving care, and that could be 8 to 11 years. We also appreciate that it's not just feeling depressed or having depression or mental health symptoms, it's really the idea of impairment. So this is how often young people experience mental illness that are interfering with how they go to school, how they live their life, and how they optimize to become their best selves. So that's about a fifth of all young people. And as I mentioned earlier, suicide really reaching epic proportions continues to be a challenge that we can all try to address together. Next slide. I don't have to remind us what we've all been through. However, when we think about the impact that the pandemic has had on all of us, but particularly with our young people, we can appreciate how devastating it has been. We've lost 1.1 million people within this country. However, when we think about the impact on children, adolescents, families, communities, it is a much larger impact. Next slide. When we think about specific communities, and I'm also inclusive of the experience of those who are living in poverty, rural areas, and other underserved communities, we acknowledge that there's been a disproportionate impact, particularly of COVID pandemic, on communities of color. Issues related to racial disparities and inequities within our systems of care are known, as well as the issues related to what we call the social determinants of health, such as food insecurity, as well as barriers to actually accessing appropriate social services as well as health services, and also issues related to financial and economic concerns have disproportionately impacted communities of color. We understand that housing is critical, as well as being able to access and get to your treatment. And as the Surgeon General has also acknowledged, we are at a point in our country where loneliness is an experience shared by many Americans, and this has a disproportionate impact specifically on communities of color as well. And then there are issues related to digital equity, such as access to virtual opportunities, not only in terms of receiving your care, that disproportionately impact these communities. Next slide. But when we think about children and young people and really experience the levels of orphanhood that many children have experienced in this country, it has once again disproportionately impacted some communities more than others. And here, really identifying the impact on racial and ethnic minoritized communities. It is now updated. Over 220,000 children in this country have lost a parent or caregiver during the pandemic, which continues to evolve. What's most concerning is that 70% of those young people who lost a parent or caregiver were under the age of 13. And when we also appreciate that many of the caregivers might have actually been their grandparents, as well as those living in single-family homes, we know that a quarter of all American children live in single-family homes. And when we look at the racial and ethnic minoritized communities, we can appreciate that for the community of the American Indian or Indigenous communities, Alaskan Natives, as well as our Native Hawaiian Pacific Islander folks, they were 3.5 times more likely to have lost a parent or a caregiver. And this was also double compared to children and adolescents who identified as white. Black and Hispanic children were more likely to lose a parent and caregiver, and for Asian Americans, 1.4 times higher. Next slide. In order to appreciate the impact also of the pandemic, as well as these times on our young people, the CDC's Youth Risk Behavior Survey gives us a wonderful opportunity to get a snapshot on what is happening with our young people. And this is done every 2 years. And the latest one done in the fall of 2021. And it's really looking over a 10-year period of time, how our young people are facing life and how they're managing through difficult times. So looking at parameters such as sexual behavior, substance use, experiencing violence, which is increasing over time, mental health and suicidality, which I'll focus on, as well as other factors which are really important, such as school connectedness, parental monitoring, as well as housing insecurity for young people are all important determinants. Next slide. When we're looking at these trends over time, focused on the mental health parameters in terms of experiencing persisting feelings of sadness and hopelessness, even though 42% of all adolescents in the survey identified these feelings, I have to acknowledge that 2/3 of teenage girls were experiencing persistent feelings of sadness and hopelessness, as well as those who would seriously considered attempting suicide. That's 1 in 5 young people have experienced that. However, these numbers are even higher when we're thinking specifically about adolescent girls, as well as those who are sexual and gender minoritized youth, as well as youth of color. So when we think about making a suicide plan, and about 1 in 5 young people in this survey acknowledged that they had made a suicide plan, and about 1 in 10, or 10% of young people had actually attempted suicide in the past year. And these are very alarming, but it's also important to note that over the 10-year period of time, all of these parameters are getting worse. The only parameter that had not changed was really those that were injured during a suicide attempt. However, when we think about those who had attempted suicide in the past year, even though it's 10%, one of the things that's important is that for adolescent females, it was 16%. And when we think about LGBTQ young people, it was 22%. And when we think about young people who had any same-sex contact or behavior, it was 33%. So we're just appreciating really the scope of the issue, but also how are we attending to the needs of our marginalized or minoritized communities within our young people as well. Next slide. Which brings me to really important moments in time when issues that are presenting themselves require a response. And so in the fall of 2021, in partnership with the American Academy of Pediatrics and the Children's Hospital Association, the American Academy of Child and Adolescent Psychiatry was privileged to partner with these wonderful colleagues who share the same mission of youth and families and communities, but also in partnership with many other organizations, declared a national state of emergency in children's mental health. And it was really a moment for action. And we knew that these issues had pre-existed during this time. However, the pandemic had made all of these issues so much worse. Next slide. Now, centering how the response can be made also needs to acknowledge what are some of the principles in which we are going to take action. And it's really important that not only with the American Academy of Pediatrics, but with also 29 other partner organizations coming together as a group and as a coalition, as a community, we acknowledge the importance of many of these different principles, including prevention, early identification, as well as early intervention, the importance of screening and identification of young people who need services, also bringing care to where the young people are, whether or not that's in their primary care clinics with pediatricians and pediatric providers, or in schools with school-based mental health. Integrated pediatric primary care is what we're going to be talking more about today, but it's also really important to acknowledge the fact that our workforce not only needs to be supported, but needs to be diverse in representing the communities that we're serving. Also, the finances related to many of these health innovations and service delivery plans need to acknowledge the importance of insurance coverage and payment, and mental health parity, which has been legislated but needs to be fully enacted. There's also the opportunities presented with telehealth, which have been really important in trying to increase access to care, and also acknowledging that there are communities within our pediatric and young people's lives, such as justice involved in other settings, foster care, etc., which need additional attention. Next slide. Now, how do we approach these? Not only with principles, but with values. And it's important that we acknowledge that family-driven, youth-guided care is important. And so I'm really appreciative of all of you who are representing those voices and really being able to champion the importance of partnership as it relates to youth and families and communities, as well as community-based, equitable care that is evidence-based, but also culturally humble and linguistically competent, and really strength-based and individualized. So we have to move beyond the labeling, as well as sort of where you are broken to where you are strong, and how we can best really take a recovery-based model, but also in terms of a strength-based model. Now, understanding where we have an impact requires that we are data-driven and outcome-oriented, and also embracing the trauma-informed care that all of our treatment needs to be nested within. So those are the principles and our values. Next slide. In terms of approaching where our principles and values fall through the gaps, much like the fragmentation of our child serving systems, whether or not they are schools or healthcare delivery settings, community-based organizations, child services, or families and communities, within those gaps are where our children and youth often fall. And within those spaces, there isn't a safety net unless we join hands and we coordinate our service systems together. Next slide. So that's why it's so important for us to be coordinated, unified, and to really be that village to serve our children and youth. And it's also really important to acknowledge the role of stigma within our communities, so being able to address those as barriers to care. Next slide. We also appreciate that it takes a village, it takes a team, and I think it's so wonderful to be able to partner with Dr. Chung through the American Academy of Pediatrics, our pediatric providers, as well as our many different partners that represent this space, but also acknowledging that there's even more people that we can involve within our community to help serve the community, and that's in partnership. Next slide. So when we think about our continuum of care, I think one of the things that's really important is, as child and adolescent psychiatrists, we can be a partner in every one of these different components. I think next slide. There's also telehealth, and where we can actually advance our efforts through our mobile as well as telepsychiatry. Next slide. And also, how can we be responsive through our 988 service systems as well as our crisis teams within our community in partnership? Next slide. And the important thing here is that we can actually move between promotion and prevention to treatment. And that's acknowledging the needs of our serious emotional disturbance and SED youth, as well as how to best provide care for them. As child and adolescent psychiatrists, we see many of these young people, often within our intensive treatment spectrum, whether or not it's partial intensive outpatient or emergency and crisis care or inpatient care. But often we need to start earlier, and that's why there are unique opportunities and partnerships, particularly with pediatricians and pediatric providers in more ambulatory settings. Next slide. The important thing here is that we don't necessarily focus on any one part of that continuum or the more intensive end of the spectrum, because that's when kids are in crisis. We need to start earlier, and that's where the behavioral health principles are so important in creating tiered levels of care where we can provide community-based universal interventions to help prevent the next wave of children and adolescents requiring more intensive mental health treatment is so critical. And child and adolescent psychiatrists, as I mentioned, can play a part in all of those different levels of care. However, we definitely partner with all of our community as well as stakeholders in trying to create that full spectrum and continuum of care. Next slide. So what's really important here is really how do we bring that village to the children? And it's really being youth-centered. And for today, we're really focused on our partnerships in terms of our primary care settings and how we can best advance and actually expand the services that are currently being provided. And that's in partnership with our wonderful pediatricians and our pediatric providers, as well as through our mental health professionals. And as I mentioned, child and adolescent psychiatrists work in team-based care with all of our mental health team members, as well as our primary care partners, as well as our youth and communities. So it's really being able to not only, instead of being silos, we can be concentric circles surrounding children and adolescents, families and youth within communities. And that's really the goal, is overall is health and well-being for our young people who are thriving within their families and communities. Next slide. There are unique opportunities presented in the primary care space. And some of these I will just touch upon, but I think that they illustrate really different models in which we can partner. And many of you have been familiar with some of these, and I'll just touch on them briefly. And we have the wonderful expertise of Dr. Chung, who will share more specifically about one of these models. Next slide. Now, first is the collaborative care model, which is really a model of care that came out of the University of Washington, really looking at evidence-based, but also population health, as well as how do we coordinate care with the pediatrician or the pediatric primary care provider to really leverage the treatment within the primary care space, utilizing a behavioral health care manager who could be a social worker or psychologist in this example, and really partnering with them so that the child and adolescent psychiatrist or children's mental health expert doesn't necessarily have to see all the children, because we can leverage the wonderful relationship that the children and families have already with their pediatrician or their pediatric provider, really sidestepping some of the stigma issues that are often barriers to care. Next slide. The other additional advantage is really looking at Project ECHO, and many of these models are really inclusive of many of these different strategies. There's the extension for community health outcomes, and that's trying to move the care to where people are at. So really being able to touch rural communities as well as more, I think, isolated communities to provide the care that they deserve. And through this model of really working specifically with the primary care providers at their site using telehealth and digital strategies to be able to advance the expertise that is practiced locally, but also leveraging the expertise of the child and adolescent psychiatrist or children mental health expert in partnership with their primary care partners. Next slide. And that's where I come to the end of my presentation, really acknowledging the wonderful HRSA-funded program, the Pediatric Mental Health Care Access Program, which currently is in 43 states, as well as tribal regions, as well as Commonwealth and other sort of republics within the South Pacific, and acknowledging the importance of these programs in expanding access and through the Safer Bipartisan Care Act, which had been enacted last year, expanding some of these reach not only to the primary care setting using telehealth, but also to schools as well as emergency departments, with specific priorities of really increasing access and availability and conducting training and additional expertise more locally, and with the efforts of really expanding health equity. And so with that, next slide, I'd like to thank you all for your time, and I'm going to pass it over to Dr. Chung, President of the American Academy of Pediatrics.
Thank you so much, Warren, and appreciate your wonderful overview. I am here to really provide that perspective from the pediatrician and really the medical side of those who take care of children. So that includes our family physicians, nurse practitioners, physician assistants as well. And so go ahead and advance to the next slide. You know, why do we even think about pediatricians? And obviously we see children, we see children all day long, we see families. We also follow them through the continuum of their development, because we know that building mental health and resilience is an important developmental task. It occurs throughout the spectrum of childhood. And so healthy mental development, how do we approach that really from a promotional and preventative perspective? And so that when we see children later who may be experiencing mental health concerns, that we've done as much as we can before that happens to try to mitigate the impact and also focus on the various factors you can see here. I won't go through all of them, but some of the factors that we all know can impact a child's development are systemic, such as disparities, across our healthcare system, and whether or not a child has a medical home, community resources, access to childcare, type of education that they have access to, interpersonal factors, right, such as systemic racism, relationships with caregivers, peers, access or exposure to traumatic experiences, mental health symptoms, and family history. So there's so many things that can impact the healthy mental emotional development of a child, that as a pediatrician, where we see them from, before, when we see them for prenatal visits, when they're shopping for a pediatrician, all the way to when they leave us as young adults, often, by age 19, 20, sometimes up to 23 or 26 even. Next slide. And as Warren went over, pediatrics is very much a place where mental health issues can be addressed, with over 50% of mental health conditions presenting before age 14, 75% before age 25. And so with pediatricians and our family physicians that see children, it is very much a place where we can intervene and work on not only the prevention and promotion, as I was talking about, as far as healthy mental development, but when there is a mental health concern, we can actually be the place where that's first identified and can be first addressed. Next slide. And we all know there are reasons why there are problems at this point, workforce being primary there, and it's also looking at payment issues. That's an area where we know that parity has not been necessarily, even though it may have been required, may not have been in place in certain areas. And that's really primarily related to public insurance. And then when we look at private insurance, that's a very different scenario. So that add to that chronic underfunding of mental health care, we have administrative barriers and treatment barriers and so forth. So all of these various issues that have led to our mental health workforce shortage get compounded when, after especially after the pandemic when we had an exacerbation of mental health concerns that we're in our current situation. Next slide. So what we really need to do is something different, right? And how do we do that transformative action? And with so many stakeholders, all of you on the call, and also you all represent different aspects of this work. And so certainly I see over my career, over the last few years, just in a wonderful coming together, I guess, of stakeholders across the continuum, working together, trying to figure out how do we wrangle this system, and how do we get to the place where every child who needs care can access it. Next slide. So pediatric primary care is one place where some work can be done, and certainly at the American Academy of Pediatrics, that is where we're primarily focused. We have a longitudinal relationship with the family. We approach it from a developmental perspective from the beginning of when they're under age 3 or under age 5, and that early childhood brain development is occurring. How do we promote positive parenting behaviors? How do we develop resilience? And teach parents how to engage with their child to develop so that their child can develop in the most healthy way. Next slide. Pediatricians see children a lot. Those of you who may have children or have been through this process know that you go to the pediatrician a lot, especially in the beginning. We see kids probably more than 15 times before age 3. And so after that, usually at least annually. And so we have opportunities. We have opportunities to engage with parents and caregivers. We have opportunities to teach and to educate. And then we also, as they get older, have opportunities to screen and determine whether or not there is a need for intervention, and then provide treatment if necessary to a degree. Next slide. Trauma-informed care is an area that we're particularly focused. Many of you are already familiar with this, but it really is thinking about that positive approach where we look at the child's strengths and looking at trauma as a whole, and not using that question of, not what's wrong with you, but what happened to you, and what's strong with you. We know that ACEs are a place where some places are screening, and that does cover some areas where children are exposed to trauma, but it's not all of it. And so we are very much working on teaching pediatricians and those who care for children on how to screen for trauma generally. And then not only screening for trauma, because you don't want to screen unless you have something you can do, but how do we teach parents how to focus on that relation and that safe, stable, nurturing relationship that's so important for a child's development, especially in those early years. Next slide. So how are we doing this? Well, we're teaching. One thing that the American Academy of Pediatrics focuses on is educational opportunities. We use Project ECHO, similar to what Warren was describing, and we do that in many ways. One example is that we have a national rural adolescent and child health ECHO training center where we teach our pediatricians and pediatric providers who are located in rural areas on how to manage and work with different conditions related to mental health. And then we're going to talk a little bit more about the pediatric mental health care access programs and how those work, if you're not familiar with them. Next slide. The Bipartisan Safer Communities Act, as Warren mentions, it really helped to fund several of these programs. We already had funding for some of them, and this act really made it possible for nearly every state and territory to have a program. I will describe these programs more detail if you're not familiar with them in a moment, using my own state as an example. I was the founder and am currently the medical director for the Virginia Mental Health Access Program, who's funded by HRSA. What we found now is that, certainly as we have more and more of these programs, that we're able to do research and that we're able to study outcomes. A recent RAND study found that 12.3% of children in states that had a program where there was ability to talk to a child psychiatrist by a primary care provider, so a teleconsultation program, received more services and were able to get more access than those in states that do not have these programs. So that by itself is a really exciting outcome. And so we know that it's starting to work and has been working in several states already. Next slide. You can see here, this is a map where you can see which states currently have funding for programs. They are all in different stages of development. Of course, some have very mature programs that have been around for decades. Other states just got funding. And so, and the wonderful part about this is that because we have programs across the country and in tribes and territories, that we're able to teach each other and we're able to collaborate. Some of the states that are not highlighted in blue have programs. They are just funded differently. And so with those included, you can see really most states should have access, pediatricians in most states should have access to these programs. So what are these programs? Next slide. I thought I'd give you a quick example of how a program came to be and what it looked like. In Virginia, I'm currently our national president of the AAP, but at the time I was our state chapter president. And as a pediatrician, I was trained, through residency to refer patients when I found, I was trained some time ago, but I was trained that when I identified a child that might have a mental health condition, that I was supposed to refer them. I was supposed to refer them to Warren or to a psychologist or social worker if they didn't need a psychiatrist, but not necessarily to manage the condition or help the family directly because that wasn't my specialty. The reality, though, is that there aren't enough child psychiatrists and there aren't enough mental health providers. And so pediatricians are having to do more and more. Right before the pandemic in 2017, I had a 14-year-old young man. He had bipolar disorder, and his child psychiatrist had just retired. And so the family reached out to my practice to say, could you help us? We've got an appointment with a new child psychiatrist, but it's about 4 to 6 months from now. And so he was on multiple medications, and what they were looking for were refills of his medications. We looked at that list, and he was on 5 different medications, and they were quite complicated. They were not medicines that we were trained to use. They were not medicines that we were comfortable using. And in our state, our Medicaid program would not pay for the medicines unless a child psychiatrist prescribed them. So what we said was, well, we can't do that, but what we can do is try to help you find care. So my practice, we called and we called and we called, and we finally found a child psychiatrist who had an appointment available, who could see him in about a month. Unfortunately, during that month, though, he ran out of his medicines, and we didn't know that would happen. And his disease got out of control. And when his disease got out of control, he got into a fight, actually in a parking lot near my office. And during that fight, he unfortunately had a weapon, and he shot and he killed somebody. So that 14-year-old ended up going to juvenile justice, and that other man lost his life. And could that have been prevented? And so I thought so. And so basically through the research, I found that there were these programs where you could do teleconsultation services with child psychiatrists. And that was located all around me in all the states around me, but Virginia didn't have one. And so we began first with going around the state essentially and saying, there are these programs, these pediatric mental health care access programs, and can we figure out how to get one in Virginia? And luckily we ran across the grant opportunity and applied for a grant from HRSA and received the grant. And then we went to our state and we asked for more funding. And so I'll tell you more about that as we go. Next slide. So let me first level set what the situation is in Virginia. Like many states across this country, we have an issue. 40% of our Virginia high schoolers were surveyed and felt sad or hopeless for more than 2 weeks in a row. 10% of our middle schoolers, 13% of our high schoolers indicated that they'd seriously attempted or considered attempting suicide. 56% of them had a plan. Next slide. And we have a workforce shortage, just like everyone else. According to the State of Mental Health in America in 2023, the one was just published, Virginia ranks 48th lowest in the country when looking at access to care for mental health. And we're 39th lowest in the country for the number of psychiatrists, psychologists, social workers, counselors, et cetera, for our young people. Only 4 of our counties have enough. Go ahead and show the next slide. And so here you can see Virginia, the green counties have enough providers, mental health providers or child psychiatrists per capita. And this is from the website from the American Academy of Child and Adolescent Psychiatrists. And we have a shortage. We have the yellow is a somewhat of a shortage. The orange is a severe shortage. And you can see the red counties don't have a child psychiatrist at all. Next slide. And we asked our pediatricians, is there a problem? It's a little hard to read here, but we asked them, do we need any help here? And absolutely the answer was a resounding yes. The first columns are looking at, is there adequate access to child psychiatry? And the answer, 98% of the pediatricians said no. And you can see why based on that map you just saw. And then, are there enough mental health services is the next question, and no. And then with the existing resources, can I take care of the kids I'm seeing who need help? And the answer was no. And then if I needed to talk to a child psychiatrist, could I even do that? And 99% said no. And so, 95% said no. Next slide. And then COVID happened. And so with COVID, of course, we saw an exacerbation of mental health conditions, and we asked our pediatricians, what are you seeing? What are you seeing in practice? And anxiety and depression, no, not surprisingly, were the most common diagnoses that our pediatricians were seeing, but really many other conditions, as you can see listed there, suicidality, other behavioral issues, ADHD, eating disorders, substance use, all were presenting in our practices. Next slide. So what is VMAP, or the Virginia Mental Health Access Program? There are 2 parts, basically education. So teaching us, how do we do this? How do we do this work? How do we learn more? We have multiple ways that we teach our pediatricians, and it's not just pediatricians, it's family physicians, nurse practitioners, and physician assistants. In many parts of Virginia, there are no pediatricians, and so our family physicians and our nurse practitioners are seeing the bulk of children in those counties. And so teaching. So we have programs like Project ECHO, we have quality improvement programs. We created a guidebook. There's a program called the REACH program out of New York, where they teach pediatricians and primary care providers over a weekend, a 2.5-day intensive little course. Basically, it's we call it a mini fellowship, but I'm sure our child psychiatrists who've actually gone through a fellowship would not appreciate us calling it that. But anyhow, it's a great program, but it does require an entire weekend. And then there's follow-up calls for case presentations for about 6 to 8 months after. Our Project ECHO programs are more in bite-sized formats where they're basically 1-hour sessions once every couple of weeks for 10 months or a year. But it is a little bit easier for those who can't manage to get away for a weekend. In the Project ECHO programs, the way that works is that in the beginning, we have a didactic session for about 20 minutes. And then after that, we have case-based learning where the participants present patients that they've been seeing. And then everyone learns how to manage patients who have that particular scenario. However, once you start doing this work, very quickly you get to the point where you need help. So with the VMAP line, that's our teleconsultation line, a pediatrician or primary care provider can call and speak to a child psychiatrist or a social worker or a psychologist or a care navigator, depending on what the needs are. So for example, I could pick up the phone and call Warren if he was on the other end and ask him, if I had a 12-year-old with an eating disorder, what do I do? I've tried this, I've tried that, and now I'm not sure what to do, and he could help me over the phone. And then we also know that that's not enough, right? We can't just treat mental health conditions through the pediatrician's office. And so resources within the community will be necessary. Long-term relationships with our psychiatrists, our social workers, our therapists, psychologists, all necessary. Support groups may be needed. So many resources working with schools, for example, and that's what our care navigators are for. So that same pediatrician, so again, I could pick up the phone and call and say, I have a 12-year-old with an eating disorder who needs a therapist. She has Medicaid or she has Blue Cross Blue Shield or whatever she has. And then our care navigators would then call the families directly and then help them find resources in their communities. So it has been a wonderful program and has changed the way that we manage conditions or patients with conditions in our practices. Next slide. And this is just another way to describe how it works. So first we learn, then we call, and then someone calls us back within 30 minutes. And so I can really take care of a child and take care of a family right away that very same day. And then you can see that the consult calls go to whichever resource is necessary. Next slide. So far, we've trained over 1,000 primary care providers in Virginia, done almost, and these numbers are a little bit out of date. We're up to almost 5,000 calls now, and we've done 22,000 hours of training. Next slide. This is just another description of how we're set up. And so we've partnered with our academic institutions all across our state. And this is where, so they're divided into hubs, and each hub has a child psychiatrist, the social worker or psychologist, and care navigators. So each hub serves a region of our state. And this has been very successful. Next slide. So we also do quality improvement projects where we teach practices how to do the screening, and we give them maintenance of certification credit, which they need for their board certifications, and continuing medical education credits. And so this is just an example of where practices started, where they weren't screening for depression and weren't screening for mental health conditions, but by the end of the project, nearly all of them were screening. Next slide. Our guidebook is a compendium, sort of a written document that can be a reference for our pediatricians and family physicians, nurse practitioners, and PAs that cover various common topics that we encounter in mental health. And we continuously update this. It's also available online. It is available for free. You're welcome to go to our website to download it and take a look at it if you're interested. Next slide. And what are people saying? Well, essentially, the reviews and the feedback that we get have been wonderful. You know, VMAP is a lifeline for pediatricians who are prescribing far more SSRIs than antibiotics this year. They help us help kids faced with months waiting for care. This service was invaluable. This patient has returned to school and is doing much better. He'll continue to see his therapist, but the service helped him get over the hump of a very difficult mental health crisis. Where this has also been helpful is that when patients are being discharged from inpatient facilities, that's been a challenge in the past. It's still somewhat of a challenge, but in the past, there was no one on the outside of the facility to receive the patient for care sometimes. And so in our communities where pediatricians and family physicians have been trained by VMAP and have the help of a child psychiatrist online on the phone, we can now receive those patients. And we have several pediatricians who have told us that, you know, they have patients that show up in their offices who have been discharged from care and they don't have an appointment for several months. And so it's been very helpful to have VMAP so that they can help take care of these children while in adolescence, while they're waiting for their next appointment. And then one other story I'll just tell you quickly. I was speaking at a conference recently, and a mother came up to me. I was talking about VMAP, and a mother came up to me and said, you know, this really works. I have two children. One is 24 years old and one is 17 years old. When my 24-year-old was going to her pediatrician, she had anxiety, she had depression, she had multiple issues, and the pediatrician didn't know what to do. They just referred us. And so when they referred her, she just had to call and try to get an appointment on her own that would take her insurance. And it was about almost a year, she said, before she got care for her daughter. Her son, who's now 17, has symptoms of depression as well. And then she said, when my pediatrician and I worked together, you know, to determine that my son had depression, my pediatrician knew exactly what to do and could help take care of him right away. So that really is impactful, and it's so exciting that these programs are really all over the country, and it's a really wonderful way to help help with the workforce issue. It doesn't solve for it. Pediatricians can't take care of everything. Of course, we're incredibly busy, but if we're able to do a little bit more, then we can certainly help and start to do more work in this space, since we really know the demand is there. Next slide. So that's the end of my part of the talk. Thank you so much for your attention. And I believe we're opening it up to questions now.
Yes, thank you so much, Dr. Chung and Dr. Ng, for your wonderful presentations. We do have several questions. One is from Corey in the chat. She said, I appreciate the emphasis placed on the value of interventions being home and community-based. Unfortunately, we encounter situations where children and adolescents present in crisis and are assessed to be a serious risk to themselves or others. Can you say a bit about when psychiatric inpatient care is appropriate and what alternatives you recommend? She did post that during Dr. Ng's portion.
Thank you so much for the question. And I think that this is an area that is continuously evolving. And so I think that the role of a psychiatric inpatient hospitalization is really the last resort, and used only when there are no other options to ensure safety for that young person. And I think that given some of the statistics that I shared related to suicide attempts, and behaviors in young people, this is something that we need to take very seriously. Now, one of the things that I would say is that the 988 and the crisis continuum service continues to evolve locally and through partnerships that are state-based. So one of the things is, depending on where you are, one of the other ways is really understanding what is your crisis continuum within your area and how does it involve particularly community partnerships as well as local stakeholders, because many of the 988 services have really tried to connect or knit together some of these resources. And some of them may actually be coordinated, ideally through your pediatric providers, your pediatricians throughout that network of care, in addition to your child and adolescent mental health program. So that would be where I would start, because I think that there's so many differences across this country. There isn't any one standard, but I would say that child and adolescent psychiatric inpatient services should be your last resort and only used in those instances where we can't ensure that young person's safety or those around them. So I think that those are particularly critical issues. And we understand that there are issues with children coming to the emergency room, as well as boarding and not being able to access inpatient hospitalization. So I'm not saying that this is something that is universally sort of easily accessed, depending on where you are. So I would almost encourage you to really think about and look into the 988 services that might be available within your area to best understand that crisis continuum.
Thank you. We also have a question from Kathleen. How do you address pediatricians who may be reluctant to participate in this model of care due to a lack of time in a busy practice?
Yeah, thank you for that question. And it's a common one. I think the reality is, the way I tend to think about it is pediatricians fall into three buckets. There's a group of pediatricians that love taking care of mental health conditions and really want to work on this and learn a lot and study a lot about it, and almost spend most of their day taking care of patients with mental health issues. There is a third that doesn't want to see it ever, and didn't become a psychiatrist for a reason. And so I think for those pediatricians, it's a little bit harder. That's more challenging, of course. But there's a whole group in the middle where this is something that they have to do. The number of kids that we see now with mental health conditions is really quite amazing how different it is. Back when I started practice, 20 years ago, there were maybe one patient every few weeks, maybe, that we might see with mental health conditions. And then now half of our day, we see children who have either developmental behavioral issues or mental health psychiatric issues, and so, or some combination of all of those, and so I think that pediatricians now are needing to do this work more than ever before. We do need to work on the way that our system's funded, though, because, I get funded the same way for a treatment of an ear infection that I might, or an asthma attack that I might for a mental health condition. Our healthcare system funding it needs some work. So that piece, I think, will have to change as we move forward, and so many of us are working on that. And I think as recognition of the importance of mental health to a person's health, it is really becoming more evident. I think, several people already knew it before, but now I think those who design our healthcare systems are starting to understand that we need to change that. So it won't happen right away, but so that is part of the issue, I think, with all pediatricians embracing this because of the time it does take, and also just the way that our healthcare system is set up. It doesn't support this at all. So.
And Gigi asked, Dr. Chung, can you speak to the importance or need for pediatricians, you mentioned funding, to be able to bill for their time using a consultation line? Is it something that AAP is trying to advocate for? It seems like it varies state to state.
It does. And one of the challenges, and so this becomes a local advocacy issue in many ways, because in adult medicine, Medicare is a federal program, and you can go to Medicare and advocate for changes. And if a change occurs, most of the adult medicine physicians benefit from that if they participate in Medicare. Pediatricians are half of children. So over 55% of children in our country are covered by Medicaid. And Medicaid has multiple variations because every state has its own Medicaid, every territory has its own Medicaid. And so instead of going to one place where you can advocate for change, now you have to go to 56 different places to advocate for change. And that's where it becomes not only a challenge, but completely an access issue and an equity issue. So the other half of children are covered by private insurance, which is also very fragmented. And so going to each payer to advocate is necessary as well. Some of those are national payers. And so certainly at AAP, we are advocating both as much as we can with Medicaid, and then also with our national private payers. There's interest, but I would say, continuing to work on that is going to be necessary to make change.
And I know we just have a few minutes left, but I want to ask, these collaborative care models seem to have arisen due to workforce shortages, which don't seem, I don't think we're going to solve the problem anytime soon, though we of course are working on it. Do you see that the future of this model, do you see it more as a Band-Aid until we can bolster the workforce fully, mental health workforce fully, or how do you see the long-term collaboration between child and adolescent psychiatrists and pediatricians?
I'm happy to answer that. I don't know if Warren, you wanted to go first, or
You go first.
Okay. So no, I don't think it's a Band-Aid. I think it's a step in a continuum. I think that this really, it's a breaking down of silos. We have benefited in my practice, for example, of having therapists in our practices, which has been wonderful. Even if they're not technically in, it might be virtual, but they're, working with us. We've hired some therapists. That's been very helpful. And that relationship building that happens between the mental health provider and the primary care provider is really necessary in order to take the best care of a child. So I think that having that is very helpful. Again, I hate to keep talking about payment, but the payment system is not structured to support this right now, though. The collaborative care model that's designed at the moment is through Medicare, again, for the adults, and involves, check-ins with our with psychiatrists, for example, every few weeks. But in the PMCH model, so the primary care mental, like VMAP model, I talk to a psychiatrist within 30 minutes. And I cannot build this code because it's not set up for that kind of collaboration. So I think there's more work to be done in that space to keep this sustainable, so that people can continue to do this work.
And I would just add in a couple of seconds, I don't think it's a Band-Aid. I think it's actually a part of the cure. I think it is our way of integrating health and mental health holistically for people-centered care. And I think that the more that we can do that in a continuum, the more impactful, because even if a young person has a serious emotional disturbance, they need their pediatrician and their pediatric provider throughout that care as well. So I think along that whole continuum, I think this partnership is really critical. Thank you.
Thank you. I have so many more questions, but I know we're at time. So thank you so much, Dr. Chung and Dr. Ng, for your time and all the work that you do every day. And thank you everyone for joining. Kelly, do you have any closing words for us?
I would just like to ask everyone to please fill out the survey as you're exiting the room. It'll show up in your browser when you click leave room or exit. I would like to thank our presenters as well. And this was a fantastic presentation. Thank you for your time and thank you for your expertise. And thank you all for joining us. Enjoy the rest of your afternoon. Bye.
Thank you. Bye.
Thank you. That concludes today's presentation. You may now disconnect.